Hello, I'm Dr. Jeffrey Hayes, Education Specialist for the American Society for Reproductive Medicine. Welcome to the latest presentation of the ASRM Grand Rounds webinar series. These webinars are designed to address topics in the ABOG Guide to Learning in Reproductive Endocrinology and Infertility. Today's presentation will be given by Dr. Lawrence M. Nelson. Dr. Nelson is currently Senior Advisor for ConoverSystems.org, Director for Strategic Alliances in the Mary Elizabeth Conover Foundation, Incorporated. The title of his talk today is Autoimmune Primary Ovarian Insufficiency, Mechanisms and Management. I will now review the details of today's presentation. After the webinar is done, please do not forget to return to ASRM eLearn to take the post-test and complete the survey for your continuing education credits. You must complete the post-test question successfully and complete the survey to receive credit and be able to print off your certificate. If you wish to ask a question to the speaker about the presentation when you return to ASRM eLearn, click on the page link labeled Questions and an email address will be provided. The question period will be open for a specific amount of time after this presentation is posted. After the time period for questions has expired, the questions page will be a frequently asked questions page pertaining to this presentation and topic. We're very excited for our talk today, so I will now turn things over to our speaker, Dr. Nelson.
Thank you very much. Well, first I just want to thank the American Society of Reproductive Medicine for inviting me to give a talk about the interface of the reproductive endocrine system and autoimmunity. This has been the focal point of my career. I've now retired from the National Institutes of Health in the United States Public Health Service, and this topic of my talk, the title of my talk is Autoimmune Primary Ovarian Insufficiency, Mechanisms and Management. And this is really the focal point of my entire career, so it's nice. I'd really appreciate the opportunity to summarize this now at the beginning of my time in retirement. And I will be working with philanthropy to try to further the mission on behalf of women with primary ovarian insufficiency. That's what I'm doing in these activities right now. Well, first, my specific purpose here is I'd like to persuade all of you regarding the importance of being vigilant for subtle signs of autoimmune endocrine disorders, and to maintain a basic competency in the evaluation and management of these conditions. Autoimmune endocrine disorders often present with subtle signs and symptoms, and yet may have potential life-threatening consequences. And I will tell you about this during this talk. Clinicians must remain vigilant and maintain this basic competency in the evaluation and management of these conditions. Turns out autoimmune POI, as we refer to it, is an excellent paradigm from which to examine the basic science of autoimmunity. It's also an excellent paradigm from which to examine the mechanisms of primary ovarian insufficiency, and an excellent paradigm from which to examine the management of infertility in general. So these are the issues and the topics that I will be covering. Merriam-Webster defines a paradigm as an outstandingly clear example or archetype. And the specific form of autoimmunity that I've been focusing on during my career in both a mouse model and in the clinic is what we call steroidogenic cell autoimmunity, which is a recognized cause of spontaneous POI. It's a result of an autoimmunity directed against steroidogenic enzymes. And it is a clear example of the presence of how an occult autoimmune disorder can have a major impact on a patient's life and the clinician's role in managing her condition. So I have nothing to disclose in terms of financial conflicts, but I have a tremendous amount to disclose in terms of my gratitude for a career which was able to pull together some work in the basic science laboratory and translate this into meaningful contributions to managing patient care. So first, I'd like to thank over 1,000 women who came to the NIH Clinical Center with primary ovarian insufficiency to participate in our research studies. Most of them at their own expense and from great distances of travel in many cases. So thank you to all those patients. I also thank the National Institutes of Health for the resources that our team was provided in order to be able to do this. and all of the mentors and the fellows and the research scientists that were part of this effort, which began there in 1988. So the learning objectives I have here today, at the conclusion of this presentation, participants should be able to, number one, outline the basic science of autoimmunity. Number two, review the pathophysiology of autoimmune primary ovarian insufficiency. And number three, describe an approach to managing autoimmune primary ovarian insufficiency. My career in OBGYN after I finished my training at the University of Southern California began in Lynchburg, Virginia, in general OBGYN. And I used to be able to look at my office and have a scene something like this. Well, I had a wake-up call while I was in private practice in Lynchburg, Virginia, that really changed the whole path of my career. This wake-up call, here's an image of Bell placing the first New York to Chicago telephone call in 1892. The wake-up call I had was a patient who I had to give a diagnosis. It was really a quite upsetting diagnosis. At the time, it was called premature menopause. And when I trained in reasonable places, and when I went to the literature to learn something about this, there was a paucity of information there. It was frustrating. Now, this patient that I first saw presented in Lynchburg with amenorrhea, I did the evaluation that she already had known primary hypothyroidism, Hashimoto's thyroiditis as a mechanism, and then she presented with amenorrhea, which turned out to have menopausal level gonadotropins, and it was the first case I ever saw of what then was called premature menopause. Now we call primary ovarian insufficiency, which is a more accurate term for this. So that started a real long journey for me to try to understand this better based on that one case. So with the NIH, we started recruiting women with 46XX spontaneous POI. They were less than 40 years of age. They had oligomenorrhea. They had menopausal level serum FSHs. They had a normal karyotype, and there was no iatrogenic cause. 90% of these cases, we don't know what the cause is, so our major objective was to try to understand the pathogenesis of this and discover new mechanisms. So we weren't recruiting women who already had a mechanism defined for the disorder. Well, this patient in Lynchburg brought important questions that are translatable into basic science and clinical investigation. She wanted to know what is wrong. She wanted to know why did this happen. She wanted to know what does this mean for my health. And she wanted to know what she should do about it. And we still have a lot to learn about this condition. But this really sets the research agenda for trying to make progress in understanding this. And I was lucky enough to do a research fellowship at the National Institutes of Health after doing a reproductive endocrine fellowship at George Washington University, and was able to focus on this disease. This is the National Institutes of Health Clinical Center. It's America's research hospital. Patients with disorders can come there and be part of the baseline evaluation at no cost to them. And I was an officer in the United States Public Health Service and retired from that with 30 years of creditable service. And I highly recommend this as an avenue if you're interested in a research career. So I got this wake-up call in Lynchburg that put me on to the fact that there might be such a thing as autoimmune primary ovarian insufficiency. And I got another major wake-up call once I was at the National Institutes of Health working on this. And the wake-up call came in the form of a woman who gave me a remarkable history. She presented to her clinic near her hometown with infertility and was set up for a diagnostic laparoscopy. And in the recovery room after that, she had a hyponatremic seizure. So, of course, they called in high-risk specialists, and it turned out in the end, she had undiagnosed adrenal insufficiency. And the physician who made the diagnosis got these photographs at the time. She had increased pigmentation. You can see this dark pigmentation. She's a Caucasian woman. She had this dark pigmentation in the lines on her wrinkles over her knuckles, and she had pigmentation in her gums. So this was a misadventure that could have been prevented if the clinicians would have been attuned to the subtle signs of potentially life-threatening primary adrenal insufficiency. So this woman had primary adrenal insufficiency as well as primary ovarian insufficiency. And adrenal insufficiency, as you know, is a life-threatening condition. And this woman unfortunately went on to have many major other issues, mental health issues. She ended up stopping her glucocorticoid replacement and had a major problem and was involved in a murder-suicide. It was really essentially related to her POI and her adrenal insufficiency. So this is a really sad outcome that we need to find a way to address in a better way. So that forms the major message of why we need to be aware of the subtle and potentially life-threatening consequences of autoimmune adrenal insufficiencies. So a brief review of the basic science of the immune system is you have here the paradigm is the antigen is presenting to an antigen-presenting cell, which is processed and then presented in a major complex molecule. This antigen is presented here to T cells. And T cells become helper cells that create either B cells that lead to antibody production, or T cells and macrophages and natural killer cells that can be involved in cellular immunity. This is the basic system of the immune function as we understand it. Now, of course, you can't have an immune system that's going to be attacking self. That's going to not be a good deal. So there are checkpoints in immune tolerance that are really important to understand. There is central tolerance, and there's a peripheral form of tolerance. And when these fail, the result is autoimmunity. Now, the central tolerance takes place in the thymus, and you have cells coming from the bone marrow transporting through the thymus, and while in the thymus, they interact with these cells that present self-antigens to them. And if they're reactive with the self, that clone of T cells is deleted. And other things can happen where the receptors on the T cell receptors can be edited to reduce their likelihood of being autoreactive. But some cells do get out of the thymus that have some reactivity with the self, so there needs to be mechanisms of peripheral tolerance to prevent autoimmunity. And that can be clonal anergy, where this T cell clone gets a stimulus that prevents it from functioning again. Or there can be growth regulation, where some cells that are autoreactive are just kind of starved off and not supported, so that reduces the autoimmunity. And then there's really clear evidence now, for a long time this was a big question, but it's clear now there are cells that can suppress autoreactive cells called T regulatory cells. So the central tolerance and the proliferance tolerance work together to avoid autoimmunity. But now, for some reason, in some situations, either the autoimmunity, the self-tolerance fails, or some other environmental factor stimulates the immune system in a way that it can cross-react with self, and you end up with an autoimmune attack against the self. And this might start off with one single antigen, but then it's normal to have what's called epitope spreading, where the destructive processes going on in the autoimmunity itself recruit other antigen processing cells and other T cells, so you have a spread of the autoimmunity to more than one epitope on that molecule and maybe even other molecules. So that's a basic summary of the autoimmune system and how autoimmunity might develop as we understand it. Now, when I went to the NIH to try to get some more insight into what's going on in this autoimmune primary ovarian insufficiency, my mentors there said, hey, Larry, you know, it's going to take you a while to develop a clinical program on this. You need to get something going in the laboratory with and there's a mouse model out there on this, so why don't you check into that and see if you can get that set up. So Roy Hertz was one of my mentors early on, a really wonderful mentor who had developed the first treatment for choriocarcinoma at the NIH many years ago. He helped me set up this mouse model, which induces autoimmune primary ovarian insufficiency by performing a neonatal thymectomy on day 3 of life. So we set this model up, and in fact, we found that thymectomy does cause an autoimmune POI. With these brown cells here are lymphocytes invading this. Here's the oocyte, here's the granulosa cells. These are lymphocytes invading the follicle of the theca in this mouse, and it goes on to destroy the ovary. It becomes a fibrous band. So it's a great model for autoimmune POI in the mouse. And interestingly, these mice also develop autoreactive antibodies which bind to the oocyte cytoplasm. So this raises a whole lot of basic science questions that we have a model in order to try to make some progress while we set up the program to recruit patients to understand this better. So this the question is, what about, we have questions about this molecule here. This is a molecule in the oocyte with immunofluorescence showing, hey, there's antibodies against it in this mouse. So there's important questions that one observation raises, and that is, what is the protein target of the anti-oocyte antibodies? What is that protein? And if we can identify the protein, what is the function of that protein? And if we can identify the function, and we show that it is what the target is, then we need to ask the question, what role does this molecule play in the pathogenesis of autoimmune lymphocytic leukeritis? So these are the questions that we set out to answer in the mouse model. So the first thing we did was a Western blot using serum from mice with the autoimmune nephritis and antibodies and from control mice that didn't develop the antibodies. And we put mouse oocytes in each lane of this Western blot. And you can see here there are mouse antibodies and blotted with mouse serum. You can see here there are mouse antibodies somewhere over 97 kD in size, which those antibodies are reacting with. And we published this in 1999. Zibin Tong was the research fellow at the time that was working with me on this. And we did use these, we used immune serum to screen an ovarian cDNA library, and we're able to pull out a gene that had not been recognized before using serum from mice with autoimmune nephritis. And we published in Endocrinology in 1999 a mouse gene encoding an oocyte antigen associated with autoimmune premature ovarian failure, we were calling it at the time. So now, okay, so we identified protein and a gene, a protein that reacts with the mouse serum. Now we want to know, well, where is that expressed in the ovary? And what's the timeline on that? And you can see here the red staining in these images show the presence of what we call mater protein, because as I'll tell you later, it's a maternal effect gene. Mater is Latin for mother. So we named the gene and the protein mater. And you can see here that in the type 2 very early stage primordial follicles, this protein is not expressed. But as soon as that follicle becomes activated and starts to grow, you see expression. And here on this Western blot, you see that it actually stays in the embryo out to the blastocyst stage, and it's not really gone until the late blastocyst stage is demonstrated here. So this is an interesting finding based on a mouse model of the human disease. So then the question comes up, do humans have this same protein? So it turned out the mouse serum cross-reacted with, this is a Western blot with oocyte protein, human oocyte protein loaded in lanes 1 and 2. And you can see that the mouse antibodies react with a 134 kD protein in human oocytes. So this confirms the fact that there is a human mater, which is demonstrated here by immunofluorescence. And here confined to the oocytes and the ovary. So now we use that knowledge to go ahead and map the gene in both the human and in the mouse, and which is depicted here. So that's what the protein target of the anti-oocyte antibodies is. It's a new protein, newly described by a newly described gene called mater. So now we're not talking about autoimmunity anymore. Now we're talking about what does this protein that we identified with the antibodies, what is its function? What would happen if we knock it out? Does it do anything important? Well, it turns out it does do really important things, because when we knocked out this mater gene and studied mater null mice, we set up mating pairs, and here's the number of mating pairs. And here's a wild type versus wild type versus knockout, wild type versus heterozygote, and male versus female. Knockout male versus a wild type female mated with. So then here's the litter sizes, and you see knockout male mice have normal number litters, but the knockout female mice have 0. So this is the mater gene is critical to early reproduction. The mice were completely sterile, the female mice. The male mice were completely normal in terms of fertility. So mater is a maternal effect gene required for early embryonic development in mice. Now this isn't about autoimmunity anymore. Again, this is about the function of the protein that we discovered with the immune serum. So this is a fascinating model we found, is that here's a pre-implantation development in the knockout mice versus the wild type mice. And you see here at day 1 after fertilization in the mouse, you've got a normal number of zygotes in the knockout and in the wild type. And 2 cells are normal. But by the time you get to the morulus stage, there's very few knockout mice that have made it to these stages of embryos. And you have morulus here with 0 morulus in the knockout. And blastocysts, there's none in the knockout. They're degenerated. looking, whereas here's the normal blastocyst. So this is a critical gene for reproduction. It's a maternal effect gene. Maternal effect genes produce products that accumulate in the egg during oogenesis. It's something stored in the egg to be used by the embryo. And they're required for normal female fertility. And null mutations cause sterility in females, but no effect in fertility in males. So this is clearly a maternal effect gene. It's an example of bedside the bench, really. We took this clinical problem to the laboratory, and we discovered a novel gene critical to reproduction. And it turns out this molecule is a founding molecule of a maternal protein complex critical to reproduction. It's the first member to be discovered. It's a novel family of proteins involved in inflammation also. So it's got more than one family. And the reproductive family that it's an important part of is the subcortical maternal complex. Here's the plasma membrane. Mater is the founding molecule of this complex. It includes philia, floclet, and TLE6. Now it turns out this subcortical maternal complex controls symmetric division of mouse zygotes by regulating F-actin proteins. And you can see here that when they knock out this member of the complex, the spindules don't form normally. So there's an important function here that's defined by this maternal complex. And it's also a member of the NLRP family, node-like receptor proteins. NLRPs are key players in inflammatory pathways. Mater was the first gene identified as a coding for a protein form of this family, from this family, NLRP5. It was the first one to be identified, but it wasn't found to be a member of this family until 4 others have been identified, so it got number 5. It's followed by the discovery of other NLRPs acting in inflammatory disorders. And it's followed by the discovery of the first maternal effect gene in humans, which is NLRP7, which is responsible for an abnormal form of human pregnancy called hydatidiform mold that you're all familiar with. So the protein is Mater. Its function is a maternal effect gene, which is critical for reproduction. So now we're back to the question about autoimmunity. What role does Mater play in the pathogenesis of autoimmune lymphocytic uveitis? We can study that in the mouse model. Okay, so what we found in studying that is autoimmune uveitis with multiple molecular targets is mitigated by transgenic expression of Mater. So Mater has something to do with the autoimmunity that develops in these mice as an inciting antigen, but it's not the whole story. And we published this in Endocrinology in 2011. So the thymectomy interferes with autoimmune regulation by some mechanism and results in ovarian autoimmunity and the production of these antibodies against Mater. Well, as we mentioned in the review of the basic science of autoimmunity, the proteins are processed into a peptide and presented to T cells by this IE histocompatibility molecule in the mouse. Well, we reasoned that if we could induce super tolerance to Mater by overexpressing Mater in the antigen-presenting cells, we might, if this is the sole inciting antigen, we might be able to actually prevent the disease. So we engineered transgenic mice to express Mater on this IE protein. So any cell that's going to be making IE, the major histocompatibility complex molecule, will also be making oodles and oodles of Mater protein. And that theoretically will induce a super tolerance to Mater. So here's the, I won't go through all the details here. You can read about it here if you want to. But this figure here just makes the point that now we've got the thymus and the spleen showing a signal for Mater. So these are the IE Mater mice. It means they're expressing a whole lot more Mater in the cells that make antigen-presenting proteins, the major histocompatibility IE. So here's the results of that specific tolerance to Mater. On the y-axis here is sera with anti-Mater antibodies. What percentage of the mice have those antibodies? And here we have these segregated by whether they have the IE Mater expression. Here these are the tolerant mice versus the control mice. So you can see here the tolerant mice have a significantly lower incidence of the Mater antibodies. So we were able to induce tolerance. And even if you only look at the mice that are histologically proven to have autoimmune uveitis, you still see there's a reduction in the incidence of anti-Mater antibodies. And over here, so that's the results of that. But over here we have a control where we measured ANA levels. thymectomy is known to induce increased levels of anti-nuclear antibodies, as you see here, but the presence of the IE matter did not change the frequency of anti-nuclear antibody levels in these thymectomized mice. So this is evidence that the tolerance we induced is specific to mater, and it's not a generalized problem with the immune response. So these mice can respond normally and get ANA antibodies, but yet they have an impaired ability to develop anti-mater antibodies, even if they have the disease. That's the point of this experiment. So now, okay, so we can induce tolerance, but the next question is, do we reduce the incidence of the disease by tolerance to mater? And yes, we do. We mitigated autoimmune oophouritis in these mice. Here on the y-axis is mice with oophouritis, the percentage, and here's whether they're expressing the IE mater, and you see here there's a significant reduction in the incidence of histologically proven oophouritis in the IE mater mice. So yes, we reduce the incidence, we mitigate the disease, but we don't erase it completely. So mater is not the whole story here. Well, it turns out, as years went by, we've got more sensitive testing in terms of the Western blots, and it turns out there are multiple molecular targets in this neonatally thymectomized-induced autoimmune oophouritis in mice. There's antibodies to mater, but there's also antibodies to these other proteins. And when you do immunofluorescence on histologic sections, you can see some mice have antibodies against oocytes, some mice have antibodies against theca and stroma without oocytes, and some have both. So there's a spectrum of autoimmunity that's the mechanism causing this. So the protein is mater, it's a maternal effect gene, and its role in the pathogenesis is it plays some role, but it's not the whole story. Okay, so now let's get back to this patient that I saw in Lynchburg and this patient that I talked to at the NIH who had a really bad outcome with autoimmune oophouritis. Let's get back to what's going on with the patient. This mouse model allowed us to get a research program going while we made efforts to start recruiting patients, and we had no problem recruiting patients because these patients didn't really have any place to go at the time. There wasn't really any significant coordinated research going on. So we actually had a waiting list to get patients in that wanted to come to see us. And we wanted to get back at the clinical center to ask these questions: what is wrong? Why did this happen to me? What does this mean for my health? And what should I do about it? These are all the questions that we had in Lynchburg. And it turns out there is such an entity as human ovarian autoimmunity. Here's the oocyte, here's granulosa cells, here's the theca, and these reddish-brown stained cells are all lymphocytes invading the theca of this ovary. That's ovarian lymphocytic oophouritis, also known as lymphocytic oophouritis. Well, Karen Coulomb in 1979 did some seminal work where she radio-labeled ovarian proteins specifically, and then she immunoprecipitated those proteins with serum from women who had what they called premature menopause at the time, and women who had normal menopause, postmenopausal, and then women with normal cycles, premenopausal. And it turns out she precipitated a lot more ovarian protein from the women that had POI, is what we would call it now, suggesting that there really is a significant proportion of these women that have this on an autoimmune basis, but we don't really know what the mechanisms of that are. So a review of the literature about human ovarian autoimmunity, we do know there are cases reported of theca cell autoimmunity, which is called steroidogenic cell autoimmune POI, steroidogenic cell autoimmunity, or lymphocytic autoimmune oophouritis. This turned out the major effort of our clinical work to understand that better. Also, other workers have identified rare cases where there are FSH receptor antibodies causing POI. And these are FSH receptor blocking immunoglobulins in patients primarily with myasthenia gravis, which can be demonstrated by competitive inhibition experiments. So there's no doubt this exists. It just turns out, as I'll show you, this is extremely rare, and we haven't been able to see it been reported in the absence of myasthenia gravis. So that's essentially the only place you see this as a form of autoimmune POI. And then there's evidence to suggest there's an autoimmunity against oocytes that can be cause of POI, and we'll talk a little bit about that. It turns out the autoimmune against oocytes is in a highly specific, rare, extremely rare population. Okay, so you might think that, okay, we can start to get a handle on who has autoimmune POI by just looking for indirect immunofluorescence using monkey ovary to see who has antibodies against something in a monkey ovary. Well, there is a test that you can run, you can order the test for these ovarian antibodies by indirect immunofluorescence, and this is a sample that has anti-zonapaloosid antibodies. as a positive control, and here's a patient sample that has them, and then here's what the negative control looked like. The problem is we studied this in detail and really found out a third of normal patients have these antibodies. Half of patients with POI have them, but a third of normal controls have it, so there's no specificity to this test. It's essentially a worthless test, so we wouldn't recommend you order that in the evaluation of this. And we checked a whole group of women with POI to see if we could find FSH receptor blocking immunoglobulins in women that don't have myasthenia gravis but have POI. And this is a positive control of anti-FSH that shows the response. And we saw no difference between control serum and serum of women with POI in terms of FSH receptor blocking antibodies. So that doesn't seem to be a very common cause of autoimmune POI. Now, it's important to understand that there can be two major mechanisms of POI, primary ovarian insufficiency. You can divide it into two processes. One is follicle depletion, which most people kind of think of this as the mechanism. They think it's like normal menopause, and you just run out of primordial follicles, and that's the cause of your POF or POI or premature menopause. But in fact, the evidence does not support that conclusion. Most patients with this condition have follicle dysfunction. In other words, they have follicles in their ovary, but they're just not working properly. And the question is, why aren't they working? Well, as you all know, you've got a follicular phase and a luteal phase of this 28-day menstrual cycle. You've got a cohort of follicles that become activated and grow in response to FSH. They produce estradiol that circulates and causes an endometrium to proliferate, so you're making a bed for this embryo to implant in. Then you have this thing called an LH surge, the formation of the corpus luteum. Progesterone is secreted. Progesterone causes a secretory endometrium to get ready for implantation. And if pregnancy doesn't happen, menses comes on. And this is how this whole ovarian cycle relates to the menstrual cycle and fertility. So now, what would be the mechanisms to have follicles in these women, but yet not have them function normally? As I mentioned, normal menopause is a follicle depletion. So over the y-axis is germ cells in millions. They peak around gestation month 4, and then gradually decline. So at an average age of 50, the functional follicles are gone, and that's the cause of the normal menopause, follicle depletion. But that's not the cause of POI in most women. It's not an early menopause. It's follicle dysfunction that's intermittent and unpredictable. Here's one remarkable case that we reported on. It's an 18-year-old young woman that got POI at age 14, and after a placebo arm of a therapy, she started having regular menstrual cycles with ovulatory progesterone levels. Now, her FSH levels were above normal, but she got back to cycling, and actually her normal cycling lasted for 2 years. So this POI can remit. And one of our early ultrasounds we saw in one of these patients, here's the bladder, here's the ovary here. You see this single follicle about 10 millimeters by 10 millimeters in this ovary. So this isn't follicle depletion in this woman. She's clearly got POI, and she's got some follicles there, but why aren't they working right? Well, we decided to get some data on how frequently do we see follicle function in women with POI. So we did weekly sampling for 4 months on women who were not on any hormone replacement therapy, measured the maximum serum estradiol each week, and then graphed the maximum E2 level over those 4 months. And each one of these dots represents a woman with POI. And this line of 50 picograms per mil represents evidence of follicle function. If you get an estradiol over 50, it's generally recognized evidence that, yeah, you have a follicle making estradiol. Well, look, over half of these women had a follicle sometime during those 4 months, which goes along with the ultrasound finding. Those are follicles. Now, are these follicles functioning normally? No. Here are normal controls on the y-axis. The serum estradiol is highly correlated with follicle dysfunction. As these follicles grow, they make a whole lot more estradiol, which is normal. So, but here in the women with POI, we measured their estradiol at the same time as measuring the diameter of their follicles, and there's a very poor, not significant correlation between the two. So this is clear evidence that these women have follicles, but they're not functioning normally. So what is keeping these follicles from functioning normally? Well, the major message is here is you cannot assume that there's follicle depletion as the cause of POI. You can't prove it definitively, even with a biopsy. Pregnancy has occurred after ovarian biopsy has shown no follicles. And we've had women turn up pregnant years after we were not able to see either ovary by ultrasound even. In fact, about 75% of these women have detectable follicles, and it's intermittent and unpredictable function, and can go on for many years after diagnosis. We had one woman who had a pregnancy at age 37 after a diagnosis of POI at age 17. Intermittent and unpredictable is the only thing you can conclude about the ovarian function in these women. Okay, so we wanted to get some histologic evidence. What's the mechanism of graft and follicle dysfunction in these women? Is this autoimmunity, or is there some other mechanism keeping these follicles from working? So we recruited women from the ages of 18 to 40 who had amenorrhea, menopausal FSH levels, and a normal karyotype. And we followed them with ultrasounds and did a graphian follicle biopsy when we could find a follicle on ultrasound 5 millimeters or greater. And they would come to the clinical center, we would take them to the OR, we would excise the follicle and do special stains and try to figure out why isn't this working. And here's a good example of one of these cases we did. Here's the transvaginal ultrasound, here's the ovary, here's a single lonely follicle, 10 millimeters by 10 millimeters. Now you know follicles when they're ready to rupture are much larger, 20 or 30 millimeters. This is only a 10 millimeter follicle, and it's a lonely follicle. Well, we took this woman to the operating room, and here's her pubis, pubic bone would be here, the umbilicus is up here. Here's her ovary delivered through this mini laparotomy incision. And you see this is not a normal ovary. This is an ovary that's got a very smooth contour to it. Normally you'd expect this to be lumpy and bumpy with all follicles in all different stages of development. Here's this single 10 millimeter lonely follicle. Well, we excised that, sent that to the laboratory, and it turns out that it's a 10 millimeter follicle that's luteinized, which is not a normal follicle. It's luteinized because you've got these pink plump luteal cells. They should be dense and blue if they're proliferating. And also you see here you've got blood vessels invading this follicle. It's trying to turn into a corpus luteum at 10 millimeters, and it's not going to work. That's what we found. And we did, and the rest of, in the other parts of the biopsy, we found very few follicles. So this is lonely follicles. So we went on and did more of these biopsies, and the first 6 biopsies we did were all luteinized grafting follicles. So statistically, that means if you see one of these on ultrasound, at least 60% of patients with antral follicles at the 95% confidence level, you can say that's a luteinized antral follicle. And they have very few other follicles on ultrasound and histologically. So now what's going on here? Well, we would call this the lonely luteinized follicle syndrome, or follicular insufficiency. Here's the physiology that's going on here. So in the normal situation, as you know, you've got FSH and LH releasing from the pituitary, traveling by the follicles and stimulating growth. And those follicles make a negative feedback in the form of estradiol and inhibin. That keeps the FSH and LH into the normal range. So one of these follicles can become dominant, the other ones die off, and it becomes the one to ovulate, release the egg, and become a corpus luteum to make the estradiol. So the whole cycle is going to work based on this normal cohort size of follicles. Now, it looks like what's happening in these women with POI, they have follicle insufficiency. They don't have the cohort. They don't have the team there helping them out with the negative feedback. So FSH and LH both go high. Now you've got a lonely follicle show up now and then, and they grow in response to the high FSH. But as soon as they develop LH receptors, as early as 10 millimeters here, they get luteinized, so they can't go on and complete the mission. So essentially, it's a deficient cohort size. It's not an absence of cohort completely, not an absence of follicles completely. And we know some of these women get pregnant unexpectedly, and the hypothesis is sometimes they just by chance have a few more follicles in their cohort so they can get these things back closer to normal and ovulate now and then and get pregnant. This is what we think is going on. But we went on and did more biopsies. The first 6 we did were all luteinized follicles. But we did go on and do more biopsies. We did find some cases of autoimmune nephritis, and this is a fascinating clinical situation. The brown stained cells here are lymphocytes infiltrating this ovary. So here's the oocyte, here's the granulosa cells, and you see, as I showed you in that human histology earlier, the infiltrated endotheca. These are steroid-producing cells that are under attack. But the critical point of this slide, in addition to that, is these primordial follicles are spared the attack. Theoretically, if we could identify a mechanism, a treatment to reduce this autoimmunity, there still would be follicles remaining that could grow and restore fertility. That was a major driving force to trying to understand this better. So what's the background on lymphocytic autoimmune nephritis? The first case reported in association with Addison's disease was in 1968 by Irving et al. That's when we first heard about lymphocytic nephritis, and it was in a patient with Addison's disease at the time. Then there was a case series of 6 reported by Irving in 1975. These are the early years of understanding that there's an autoimmune lymphocytic oophouritis. Since then, only 1 of 28 reported cases is associated Addison disease at presentation. It's more common for the Addison disease to show up subsequently to the autoimmune oophouritis. In 9 of 10 cases, when both are present, the ovarian insufficiency appears first. That wasn't the case in the woman that I had the tragic outcome that I explained to you. She had the Addison disease show up first. But in 9 out of 10 cases, the POI shows up before the Addison's disease, which means, as clinicians, we need to be attuned to the fact that a woman with POI may well develop Addison's disease in the future, and it's a potentially life-threatening condition. So this is a major point of this talk. We need to be aware of those subtle things. So I told you about this woman that clinicians in her hometown missed this diagnosis, and she ended up with a hyponatremic seizure. And so we want to try to avoid that. The prevalence of steroid-genetic cell autoimmunity in 46XXPOI, what is that? Well, we, in our program, tested 266 women in whom POI was their primary concern, and they all had a normal karyotype. Overall, 10 of 266 women tested positive for adrenal cortex autoantibodies, which is only around 4%. So it's a small percentage of the women with POI that appear to have steroid-genetic cell autoimmunity as a mechanism. It's a small percentage, but nevertheless, it's an important percentage because these are the women that could be at risk for Addison's disease that you need to detect. So the mechanisms are follicle depletion and follicle dysfunction. And the transvaginal ultrasound scan from a patient with this POI due to autoimmune nephritis shows multiple follicles. These patients have multiple follicles, and they can get enlarged ovaries. They can torse. And here's a histology showing lymphocytic oophouritis on one of the patients that we identified in our ovarian biopsy protocol. So here you see this could actually be mistaken for a polycystic ovary on ultrasound. But yet this woman has this lymphocytic infiltration in the theca, so she definitely has autoimmune nephritis. And adrenal antibodies by immunofluorescence, this is patient sera immunoblotted against monkey adrenal, showing this green fluorescence, and patient means the patient has anti-adrenal antibodies. Well, these anti-adrenal antibodies are present in 28 of 28 known cases of confirmed autoimmune nephritis. So the lower confidence interval is 92%. And then it is not found in any of 375 normal controls. So the chance of finding those is, by confidence interval, is less than 1%. So there's a good correlation between the presence of adrenal antibodies and the presence of autoimmune nephritis as determined histologically. And we conducted a prospective assessment of this by measuring adrenal antibodies and doing biopsies to determine if autoimmune nephritis was present or not. So we had 4 cases in this series in which oophouritis was present histologically, and 6 patients in this series in which oophouritis was not present. And if the antibodies, and when you do the statistics on this, if the presence of the positive antibodies with the positive finding of oophouritis are all in this cell, and the chance of that happening statistically is low, so we can conclude that anti-adrenal antibodies are a good marker to detect autoimmune oophouritis, and we can dispense with the need to do ovarian biopsies. And our IRB agreed with that, so there's no need to do biopsies anymore to prove this diagnosis. All you need to do is to test for adrenal antibodies. Now, it turns out there are antibodies against several steroidogenic enzymes in these women, against P450 side chain cleavage, against 17-hydroxylase, and against 21-hydroxylase. This is a clinically available test, and we did show that the presence of 21-hydroxylase antibodies correlates very, very well with the presence of adrenal autoantibodies as indirect immunofluorescence. So this is a clinically indicated test that's readily available and accurate, measuring anti-adrenal 21-hydroxylase antibodies by immunoprecipitation. You can order it through your standard laboratories. Okay, so now back to what are the mechanisms of POI overall. This talk has been about steroid-genetic cell autoimmunity. It only explains about 4%. 90% are still idiopathic. 6% are due to the FMR1 premutation, which we don't have time to go in here today, but it could be a subject of another talk. And there are these rare genetic mechanisms like FSH receptor mutations that they're not clinically indicated to test for at this point. So we still have a long way to go. So some summary information about lymphocytic uveitis from reports in the literature that Bacaloff pulled together, about 35 cases between the ages of 17 and 48. All of them had adrenal antibodies positive. A lot of them had ovarian antibodies positive, but not all of them. So that, and as we said before, the specificity of this is poor, so these aren't worthless. These are pretty worthless. And 8 out of the 35 had Addison's disease at presentation, so a minority had it at that time. And the ovarian size of surgery can vary. They can be small, normal size, or even enlarged and multicystic. Actually, most of them are enlarged and multicystic, 59% here in this series that Bacaloff pulled together. So now the other, and in our series of 4 cases that we had, there was a variation in ovarian volume here from 28.6 was the largest. And this interesting work by Corrine Welt, when she was at Harvard, showed that these follicles have a selective theca cell dysfunction in steroidogenic cell autoimmunity. You notice FSH and LH are high, estradiol is low, but these inhibin levels in these women are above normal. So the ability of the granulosa cells to make inhibin is not under attack, and this is a distinguishing factor in the clinical measurement, clinical evaluation of these women. Another interesting thing is women with steroidogenic cell antibodies and POI have higher AMH levels than women with idiopathic POI. So it is true that they're much more likely to have primordial follicles remaining in the ovary, and with the right formula of immunosuppression, you might be able to get those follicles working again. But some of the disappointing news is the serum AMH levels, when you look for the duration of the disease, decline. So it seems like there may be a window in the first 5 years or so of women having this steroidogenic cell POI and having some follicles left. But as you go out beyond that, the AMH levels go down really low, so it looks like there is a destruction of these over the years after the onset. So adrenal antibodies by immunofluorescence are highly associated with histologically confirmed autoimmune nephritis. They may mark a long preclinical course leading to Addison's disease. So we need to be aware of the signs and symptoms of that. And also, they're a useful screening test for asymptomatic adrenal insufficiency. So women with autoimmune nephritis may have a reversible cause of POI. They may be misdiagnosed as PCOS if you just look by ultrasound. And they are at risk of potentially fatal adrenal insufficiency. We reviewed the fact that these are the autoantibodies in steroidogenic cell autoimmunity. And then there's these other types of antibodies, but does oocyte autoimmunity play a role in the POI, which we'll come back to later? And we answered the question, there is a human martyr. So if so, we can ask the question, is there a form of autoimmunity in the human that causes POI that's directed at oocyte proteins, as we found in the mouse? So let's produce recombinant martyr protein, produce a recombinant control protein, and test patients' serum with POI with ELISA to see if there's a higher incidence of martyr antibodies. So we went ahead and did that. And what turned out in the general population of women with POI, we did not find an increased incidence of those. But it turns out, interestingly, in this APOSED, APS1, or autoimmune polyglandular candidiasis ectodermal dystrophy, autoimmune polyglandular failure type 1. It's a rare disease that's due to a mutation in the AIR gene for the autoimmune regulatory gene. It's associated with early onset hypoparathyroidism, and in some cases, alopecia, which is demonstrated here. It maps to this location on the gene. As I mentioned, it's an autoimmune regulator gene. The protein is AIRE. Its transcription factor is localized in the nucleus. It's got zinc finger motifs. It induces expression of numerous peripheral tissue self-antigens in thymic stromal cells. It's a complicated situation. It was actually, the presence of this gene was discovered by clinical research. Well, the exciting thing about this is MATR, or NALP5 as it's been called, autoantibodies and autoimmune polyglandular failure syndrome are related. It turns out this is a clinical finding, APS1, and these are the clinical findings here in patients with APS1. In hypoparathyroidism, 73 out of 87 of the cases of this had hypoparathyroidism, and look, half of them had NALP5 antibodies, and none without. So that's highly significant. So NALP5 antibodies, MATR antibodies, autoantibodies, correlate with the presence of hypoparathyroidism in this population. And you know what? The same is true for hypogonadism. Women with POI with this disorder, a third of them with APS1 had POI. 19 out of 28, or 68%, had moderate antibodies. But if they didn't have POI, only 29% had antibodies. So overall, that's highly significant. Hypogonadism is associated with anti-moderate antibodies in APS1. So that seems to be the only situation where anti-oocyte proteins are a mechanism of POI as far as we understand right now. So now there's the question is, are there other oocyte antigens involved in autoimmunity in these women that we just haven't been able to identify yet? And that really seminal work that I referred to with the immunoprecipitation studies of radiolabeled protein would suggest that these exist, but we just don't know about them yet. So the learning objectives were outline the basic science of autoimmunity, which we did, review the pathophysiology of autoimmune primary ovarian insufficiency, which we did, and reviewing our research on that and the current state of the literature. Next thing is to describe an approach to managing autoimmune POI. This is what we will do next. Well, our team got many wake-up calls over the years working on this condition at the NIH Clinical Center. We got wake-up calls about endocrine health. We got wake-up calls about emotional health. We got wake-up calls about surprises about these women's reproductive health and surprises about their genetic health. This disorder covers a wide spectrum of issues for patients, all of which are in need of in-depth basic science and clinical research tied together, which is members of ASRM have a special calling to do this translational research that ties together the basic science and what we're doing in the clinic. So those fellows of you out there now that are working on your thesis, there can be a really exciting road ahead for you. Well, having a whole team come together at NIH to work on this allowed us to really become a recognized center on POI. So we were asked to do the review article by the New England Journal of Medicine, which we published in 2009, which focusing on a rare disease can lead all of you fellows out there to becoming an expert in something that other people aren't working on. So in spontaneous primary ovarian insufficiency, the baseline tests we suggest are adrenal antibodies by indirect immunofluorescence, or 21-hydroxylase antibodies by immunoprecipitation. And this is probably the only test you need to do now to detect adrenal antibodies, because it's readily available and highly standardized, and these may not be. So measure the 21-hydroxylase to determine if your patients with POI have autoimmune nephritis. If those are positive, you can make that diagnosis without a diagnosis. Then there is an increased incidence of autoimmune thyroid disease in women with POI, so we recommend you check for thyroid peroxidase antibodies. And you should get a karyotype. Some of these women will have a mosaic Turner that will explain their POI. And the FMR1 premutation, which could be another talk some other time, is another cause that you need to test for. So those are the clinically indicated tests to get the mechanism. Now, how about managing specifically steroidogenic cell autoimmune POI? Since these women are at risk for life-threatening adrenal insufficiency, we recommend an ACH stimulation test each year, one a diagnosis, and every 1 or 2 years if that's normal. And they need to have a bracelet notifying healthcare providers and emergency teams if they have asymptomatic adrenal insufficiency. If they fail this test, they will need supplementation in critical situations. And we need to inform these women of the symptoms of adrenal insufficiency, which are loss of appetite, weight loss, fatigue, orthostatic symptoms, salt craving, darkening of skin. This woman I told you about that ended up with a seizure in the recovery room due to hyponatremia, she was telling me she used to come home from work early to drink pickle juice. She was having so much salt craving, she was craving pickle juice, which is an amazing, amazing symptom that was missed. So conclusions here. The pathophysiology of autoimmune primary ovarian insufficiency differs from the normal menopause. Lymphocytic autoimmune nephritis is associated with steroidogenic cell autoimmunity and adrenal insufficiency. Patients with steroidogenic cell autoimmune POI should be evaluated and followed for the possibility of asymptomatic adrenal insufficiency. So again, I thank the American Society of Reproductive Medicine for the great work they do in educating us all about the different aspects of normal reproduction and the disorders of reproduction and the interface of basic science and clinical science, and trying to unravel the mysteries around this.